HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Dr. Jason Kovacic on spontaneous coronary artery dissection, or SCAD. Dr. Kovacic, tell us about yourself.
Yeah, thanks, David. Please call me Jason. It's great to do this, and I'm really thrilled to be able to speak about spontaneous coronary artery dissection and fibromuscular dysplasia. So yeah, I'm a physician scientist. I'm a practicing cardiologist. I practice at St Vincent's Hospital, Sydney, Australia. I also have an appointment at the Icahn School of Medicine at Mount Sinai and have a small lab there of just a couple of people. And in fact, I was at Mount Sinai for about 11 years and still maintain that small team there. As well as those things, I'm the Executive Director and CEO of the Victor Chang Cardiac Research Institute here in Sydney. And at the Victor Chang, I oversee what's now a national institute with about 25 labs and some 250 faculty and operations teams. So it keeps me busy, but my main research focus is vascular disease, particularly spontaneous coronary artery dissection and fibromuscular dysplasia.
In this podcast, we're just going to focus on spontaneous coronary artery dissection. Just to make sure that all our listeners are on the same page, Jason, what is spontaneous coronary artery dissection?
Yeah, thank you, David. So spontaneous coronary artery dissection, or let's just call it SCAD. SCAD is a disease that is not rare, but not common. It's sort of, I think of it as uncommon. It's actually the most common cause of heart attack in women under 50. And it is effectively a tearing of the coronary arteries, the arteries of the heart. So the medical word for tearing is dissection. And there's some subtle differences technically between a tear and a dissection, but more or less it's a tearing of the arteries of the heart. And that tearing, we now understand, is mostly due not actually by a tear itself. It's set up by probably bleeding into the wall of the artery. And what happens, probably some small blood vessels rupture and they cause a hematoma or a sort of blood clot to track along the wall of the artery. And as that expanding blood clot moves up and down the wall of the artery, it tears the artery as it goes along. So that's effectively SCAD. There's also probably a type of SCAD where the true lining of the artery wall actually tears. And those two forms are what we commonly see in the clinic.
I might go into those forms later in the talk, but what are the symptoms of SCAD? Does it differ from other types of myocardial infarctions?
Yeah, great question. So SCAD is just a cause of heart attack. And at the end of the day, a heart attack arises due to a lack of blood supply to the heart muscle. And most types of heart attack due to a blockage of the heart artery. And it doesn't matter whether it's because of a regular plaque rupture. So that the common type of heart attack is due to a disease called atherosclerosis, where you get buildup of fatty plaque in the arteries. If atherosclerosis causes a coronary artery to block, or if SCAD causes a coronary artery to block, still at the end of the day, the end result is cardiac ischemia or a lack of blood supply. So it's just another form of heart attack.
Jason, you mentioned that SCAD is the most common cause of heart attacks in women under 50. Overall, it's, if you like, uncommon. What sorts of incidences are we looking at in women under 50? What's it in terms of cause of death?
Yeah, so in terms of cause of death, that's a tough one because we've looked at that specific question in some of our research studies, never published it. But one of the challenges with looking at autopsies and post-mortem, so what can happen? Someone can die of a cardiac arrest. As you know, if people have a massive heart attack, they just die of a cardiac arrest. And then they may go on to post-mortem. And if a massive SCAD goes to postmortem, as you know, the postmortems usually don't happen for a day or so. And then what happens is at postmortem, everything's just clotted up.
Okay.
And it's really impossible, I think, for the people doing the postmortems to understand what is a blood clot that's just because there's been no blood flow for 24 hours versus what was actually a blood clot because there was SCAD and tearing. And, there's often been CPR going on. It can be a little bit difficult. So the true incidence of SCAD causing cardiac arrest and sudden cardiac death in the community, we don't really know. And I think it's actually difficult to address that question. It's also known that a lot of SCAD has probably been missed over the years. I think we're getting better at making a diagnosis, but you can imagine in the past, young woman, 30 years old, comes in with chest pain, and she gets worked up for, pneumonia, maybe a pulmonary embolism, but no one's thinking of a myocardial infarction in a 30-year-old woman. So probably a lot of SCAD was missed. So we're not really sure of the true incidences, but it probably, it is the most common cause of heart attack in women under 50, probably accounts for around 4 to 5% of MIs in that group. What the incidence is in other groups, it's still not clear, but it's not rare. I mean, I go on call for cardiology at St Vincent's Hospital in Sydney, and I've had several people admitted under my care this year from SCAD, just being on call, and they've just come in through the front door. So at St Vincent's Hospital, we'd probably see in the range of, I think, 3 to 8 SCAD cases every year. It might be a bit more sometimes, but it's not a super rare condition at all.
Having said that, and I'll come back to this as well, Jason, is that we will miss as a GP this 30-year-old woman coming in with chest pain because it's just so unusual in our minds that it will go under our radar. And of course, one of the questions I'll put to you later is how can we raise our awareness and lower the threshold? Having said that, what actually causes SCAD?
Right. That's the key question, isn't it? So, I mean, this is one of the things about SCAD that I hear all the time. Like, it's a mysterious disease. We don't understand it. We don't know what causes it. That's not true. So we actually have made incredible progress on understanding the cause of SCAD. I think it's still thought of to be this kind of mysterious, weird disease because, it's causing heart attack in young women. That's sort of not within our regular frame of reference. But the cause of it is actually getting pretty well known. So we've done a lot of work. In fact, that's been sort of my career on understanding the cause of SCAD. And it's a combination of both genetics and environment. Like so many of the diseases we see in medicine are a combination of those two things. And so the genetics we know, we've now found, upwards of around 20 genes that are involved in SCAD. The first gene ever identified that was linked to SCAD is a gene called factor 1. And in fact, my lab here at the Victor Chan Cardiac Research Institute in Sydney has been working specifically on factor 1 for the last 3 or 4 years. We just submitted a manuscript on factor 1 yesterday, in fact. Factor 1's a complex gene, and we're still working out how that works. But to put it in context, some of the other genes we've found clearly indicating a problem with collagen and matrix. And, your listeners will know, practitioners will know that collagen and matrix is responsible for tissue integrity, tissue elasticity, tissue recoil. And you could easily imagine when you perturb collagen and matrix, it's a setup for things like arterial dissection. And even in diseases that are somewhat related to SCAD, like Marfan's disease, like Ehlers-Danlos disease, where there can also be arterial dissection events, those are also diseases of collagen and matrix. And if we take, for example, Ehlers-Danlos disease, where you can have joint hypermobility, you can have arterial dissections, soft tissue problems. Vascular Ehlers-Danlos is caused by gene mutations, mostly in the gene collagen 3A1. And in fact, we've also found collagen 3A1 can be involved in SCAD. So it's a collagen matrix problem. Most of the genes are involved with collagen matrix, but there's also, as I said, environmental influences. So stress is a common, not a universal, but a common feature of people presenting with SCAD. So overwhelming emotional stress, which probably leads to adrenergic surges, adrenaline, noradrenaline surges. And more common in males can be extreme physical activity. So, super heavy weightlifting or things like that. So those things combined, SCAD can occur out of the blue. And they've got one patient who had SCAD while she was unwrapping Christmas presents. So it doesn't have to be stress or physical exertion, but mostly there is those accompaniments. And there are overlaps of SCAD with Takotsubo cardiomyopathy. So that's broken heart syndrome. With Takotsubo, there's also adrenergic surges. There can also be vasospasm, and perhaps even those conditions, SCAD and Takotsubo, overlap more than we've appreciated in the past.
That's phenomenally interesting, isn't it? I also wonder whether or not having have collagen that's not as good as can be, would hypertension then make the issue worse?
Yeah, so great question. Hypertension is present in about a third to 50% of women with SCAD, depending on their age. Less common in younger women, but in women, say, are in their 50s with SCAD, having hypertension is fairly common. So that's about 50% of women. Whether it definitely is an accompanying feature, whether it's a causal feature or not, is a great question, but we do see that quite commonly. Another interesting thing to say is the other common accompaniment of SCAD is fibromuscular dysplasia, which we'll speak about in a separate podcast. But of women that come in with SCAD, about 50% have fibromuscular dysplasia. So these two conditions do overlap, and in some contexts, I actually believe they are the same condition, just manifesting differently in different arterial beds.
Oh, this is so interesting, Jason. Just a thought occurring in my mind because it just comes on spontaneously, and hypertension can be there for long periods of time. I
Hmm.
wonder whether people with labile hypertension might be at particular risk.
Yeah, sure. Labile hypertension, I think, is a trigger in some people. So I definitely have had people that, blood pressure out of control, sort of 180, 200 systolic, and then the next thing they know, they're in the emergency room having SCAD. So that's definitely actually an important cause in some people. But thankfully, that sort of malignant hypertension picture is much less common now than it used to be decades ago.
Now, having said all this, the question remains, why is it more predominant in women
Great
and healthy
question.
ones at that?
Yeah, David. So brilliant question. So we presume there's hormonal factors here, and it's interesting that there is definitely groups of women that happily don't have any major medical problems until they get to menopause, and then they start having SCAD. And we used to think SCAD was probably a disease related to estrogen and progesterone, but perhaps we're evolving in our thinking, and SCAD may be in some women related to changing hormonal levels. And I've definitely had SCAD happen in young women where they're nowhere near menopause, say in their 30s. I've definitely had SCAD happen in women where they're past menopause, they're in their mid 60s. But there's some women that just get to menopause and start having SCAD in the perimenopausal period. So hormones are a factor, but it may be it's changing hormonal levels or fluctuating hormonal levels more so than an excess of estrogen or a deficiency of estrogen. What's also clear now, David, is that there's a lot of data emerging that even in atherosclerosis, there are fundamental differences in the arterial wall between males and females. And if you do, advanced genetic sequencing studies of the genes expressed in, for example, smooth muscle cells in the arterial wall, they are not the same between males and females. And in fact, we now have data to indicate differences in the arterial wall are likely implicated in SCAD. We're just getting started on that line of inquiry and that understanding. So I don't have a lot of depth in that, but I do now firmly believe that there are just intrinsic differences in the arterial wall that are unrelated to hormone factors that are also critical in the sex differences between SCAD for males and females.
I look forward to your research, Jason, because it looks like you might come up with novel risk factors that we are not even looking at or thinking about.
Yeah, I think we are actually doing that. For example, I can let you know, factor one is the first gene we ever linked to SCAD and fibromuscular dysplasia. Factor one is a very complex gene, but we've been studying it for years here in my lab at the Victor Chang Cardiac Research Institute. When we look at arteries of mice where we've deleted that gene, there are clear differences in their responses to different stimuli. So in the way they relax and contract. So their vasoconstriction, vasoreaction is completely different to different stimuli. And I think that is only due to intrinsic sex differences in the vessel wall between males and females. So we've got a lot to learn, but I think what's exciting here is that we're actually learning a lot through SCAD about just fundamentals of biology and disease pathology. And probably another, I think this is a very simplistic analogy that I share here, but one that I often share with my patients is that we've actually learned from our SCAD studies, David, that the genetics of SCAD are protective against atherosclerosis. And in fact, if you've got about half the genes we've linked to SCAD are inversely linked to atherosclerosis. That's to say that a gene that's causative for SCAD will be protective against atherosclerosis and vice versa. And I now tell my patients, look, it's the silver lining to the cloud of having SCAD, is that if you've had a SCAD, you're actually genetically less likely to go on and develop atherosclerosis. And the two diseases aren't mutually exclusive, but I am yet to see a SCAD patient with significant atherosclerotic disease. They just don't coexist together. And I think what we're understanding, and this is exactly the analogy I tell my patients, is that we actually call atherosclerosis hardening of the arteries. And what's the opposite of hard arteries? It's soft arteries. And what happens if your arteries are soft? Well, they probably dissect and tear. So I think there is a lot of logic in that analogy, and patients can, readily appreciate that their arteries are perhaps a little on the soft side, and so they've had a tear, but they're protected against hardening of the arteries. And I think that speaks to other elements of SCAD. SCAD is it can arise in the peripartum period around the time of childbirth. And in fact, it's way, way the most common cause of heart attack at the time of childbirth. And why is that? Well, at the time of childbirth, there are major hormonal changes that allow softening of the birth canal, softening of the cervix to allow the baby to pass out the birth canal. And those same hormones that soften the birth canal probably also just soften the arteries of the heart and set up in a small proportion of women to having SCAD around the time of childbirth. So I think that analogy, it's quite a simple one and probably overly simplistic, but nevertheless, I think it serves a good purpose, and I think it's an analogy that patients can readily grasp.
I love that analogy, but it's so fascinating. I look forward to your work in the future. Now, you have raised two issues that are of concern now that you've managed it to GPs, because we're dealing with women in the childbearing age. And, do we diagnose? Do we screen? What do we tell the women who may be positive or actually screened out to be at risk when they're having a baby? But before we get there, because that's the question that's just sitting on my mind, the first question is this: are we getting better as GPs and specialists at actually diagnosing patients with SCAD?
Yeah, I think there's no question we are getting better. And the troponin assay is our friend here. So I've had several SCAD patients, and even the patients themselves, 30-year-old female with chest pain, she's not thinking she's having a heart attack. So they do often present to the GP as the first port of call. They think, well, I can't, well, I'm 30, what could be wrong here? So they'll go to the GP, and the GPs may order a bunch of blood tests, including a troponin. And I've had I've had a few calls from GPs, 6 o'clock in the evening. I've got this 30-year-old woman, her troponin's 100 or 1,000. I'm sending into the ER. Right. Thank you. So I think that's a great tool. ECG diagnosis, it can be more subtle. SCAD can affect distal vessels. The ECG changes can be subtle. Sometimes it's diagnostic, sometimes it's not. But an elevated troponin, for whatever reason, it still may be pericarditis, it might be tachycerebral cardiomyopathy, it might be coronary spasm. There's other differentials, but an elevated troponin is obviously a clear reason someone needs to be going to the ER. So I think that's been incredibly helpful. But I think also just the awareness that people of all ages can suffer myocardial infarction, and just because they're 30 and they're healthy doesn't mean they can't be having a myocardial infarction.
So your takeaway point is that it doesn't really matter the age, maybe even the gender, but if you've got a suspicious chest pain, just make sure you put a troponin with the blood.
Yeah. And if you're worried, just send them straight to the ER, because
Okay.
these things do happen, and it may not be a SCAD, it might be a pulmonary embolus. And, so I often,
Yeah.
if I get these questions from so I'm on call for cardiology, if the ER is calling me and they've got this, look, I've got this atypical chest pain, it's a bit of this, it's a bit of that, I make sure they've done a troponin and a D-dimer before I'm sending them home from the ER, because many times I've been called with someone they think is having an acute coronary syndrome and they're having a PE, or vice versa. They can be a difficult diagnosis to separate in people. So I think that's a really good tip. And I often tell the residents that if someone's having a STEMI, it's easy, right? If someone's coming with atypical chest pain and you're not sure, I think if you're ordering a troponin, it's helpful to also order a D-dimer at the same time.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
Now, away from diagnosis, we're coming back to that tricky question of screening.
Yeah.
Is it possible that we can screen a patient?
Yeah. So for people at risk of SCAD, the trick to that is that SCAD is linked to fibromuscular dysplasia, and that's going to be the topic of a separate podcast. So I won't say too much here, but we don't specifically look for SCAD. We don't screen for SCAD as such. What we screen for is arteriopathy changes that can manifest as fibromuscular dysplasia, and that can include in the renal arteries, the carotid arteries, and other arteries. There is no hallmark of people at risk of SCAD in the coronary arteries. So doing a CT coronary angiogram, for example, or a stress test isn't helpful. But for screening, we can look for fibromuscular dysplasia, and that's something we'll talk about in another podcast.
Very good. Just a quick bit of advice to GPs when, a woman, for example, tells us that in the family, someone close has had a heart attack, a woman at a young age, and she's intending to have a child. Are there particular bits of advice we need to give or not?
So that's a great question. So if in the context of SCAD, I'll take this question. So if a woman has had SCAD and they're contemplating pregnancy, they need to be in the hands of a specialist to begin with. I have managed women through pregnancy that have had a prior SCAD. And I'll tell you that my rules, and this is no guidelines, there's very little clinical data, but nevertheless, these are my pretty hard rules on this. I will agree to manage a woman through a pregnancy if she's had a previous SCAD on the conditions that, number one, the previous SCAD was not a peripartum SCAD. Okay. So if it was a peripartum SCAD, I'm not agreeing to sanction any pregnancy. That I think if it's been a peripartum SCAD, I wouldn't recommend any further pregnancy. Yeah. If the SCAD was not at the time of childbirth, so that's the ones I'll agree to sanction a pregnancy. If they've had a SCAD that was not at the time of childbirth, if they've been at least a year out from that SCAD, if they're not having any ongoing chest pain, because occasionally people will get chest pain after SCAD due to microvascular angina, they've got to be chest pain free. And I usually also send them for genetic testing, because in a proportion of SCAD patients, about 10%, we can find syndromic conditions like vascular Ehlers-Danlos, Marfan's disease, other connective tissue diseases. So I want to rule out that they've got a significant arteriopathy underlying this SCAD. If all of those conditions are met, so not a peripartum SCAD, genetic diag testing negative, no chest pain, at least a year after SCAD, and they're going to come and see me in the clinic, and we can put together a high-risk OBGYN team around them, then I'll agree to sanction their pregnancy. The ultimate decision of getting pregnant or not is obviously not my decision, it's their decision. But my decision here is whether I'll sanction it and whether I think it's a reasonable and safe thing. I can't tell you who, of course, but I was thrilled to receive a Christmas card a couple of days ago from a family where we did all of this, and she safely delivered a healthy baby, and it was one of the highlights of my week, actually. And the international experience on this is that it can be done safely, but it really needs to be in very specialist hands. These women need to be very, very closely watched. As we've already said, people with SCAD and fibromuscular dysplasia do tend to have more elevated blood pressure than general women of that same age group. So very close watching of blood pressure, low threshold to start blood pressure medication during pregnancy, particularly things like low pressor. Low pressors are one of the medications commonly used in pregnancy, and beta blockade is one of the therapies we commonly use in SCAD patients. So the short answer, yes, but I'm very fussy about how it's done.
And it's certainly something we would want to refer away fairly quickly for special advice. Now, looking at the pathophysiology of SCAD and myocardial infarction due to atherosclerosis, it sounds so very different. Are they treated the same after they infarcted or during the infarction?
Yeah, that's a really important question. So at present there are actually no randomized clinical trial data whatsoever on how to manage SCAD. Absolutely nothing. So everything I'm going to tell you now is anecdotal, expert consensus, retrospective case study kind of data. So what we know is that aspirin is usually given because the artery tears and then there's usually a blood clot. So the same as when an atherosclerotic plaque ruptures and there's a blood clot and the artery blocks off, the same happens in SCAD. The artery tears, there's exposure of the subintima, and that clots, or the vessel is tightly narrowed down due to intramural hematoma and the vessel clots off. So we do give aspirin and sometimes clopidogrel, or often clopidogrel, knowing, however, though, that the primary pathology may have been an intramural hematoma and actually a bleeding event in the arterial wall. So whilst we may give aspirin and clopidogrel, we don't use more aggressive agents like aspirin and ticagrelor or prasugrel. We know that spontaneous coronary artery dissection tends to heal if we leave it alone. So whilst they may go to the catheterization laboratory, in the laboratory, interventional cardiologists will generally not treat or not stent if the patient is stable and if there's flow in the vessel. So we will only stent if they're having ongoing major ischemia, they're running into other complications, heart failure, ventricular tachycardia, and so on. So if they're conservatively managed, which is about 2/3 to 70% are conservatively managed these days, we do like to use beta blockers. And beta blockers reduce arterial shear. They've also been shown in other conditions like Marfan's disease. We give beta blockers in Marfan's disease to reduce the recurrence rate or the risk of aortic dissection. So beta blockers, judicious use of aspirin and clopidogrel. We tend not to use statins unless LDL is elevated, and we just treat to target. So for most women with SCAD, we don't actually use statins. If blood pressure is elevated, we like to use ARBs, so angiotensin receptor blockers. And that's, again, just borrowing from the Marfan's literature, where there is data to show that in Marfan's, which is another aortic arterial dissection condition, that ARBs and also beta blockers, as I said, can be beneficial. So often for ongoing care of SCAD, we'll tend to stop the clopidogrel pretty early after about a month or so. So they'll end up on aspirin a beta blocker, and maybe an ARB if there's blood pressure. And then we try to get them to tolerate an ongoing beta blocker lifelong if that's possible. We'll often stop the aspirin at about a year or something like that, so they'll end up on no antiplatelet therapy, and then it'll be beta blocker lifelong plus minus ARB if they've got blood pressure. And interestingly, as you can imagine, young women don't like beta blockers. That makes them feel tired, lethargic. Nightmares can be more problem. Nightmares is a side effect of beta blockers, which older people don't tend to have much of a problem with it, but younger people do. But I am pretty persistent with the beta blockers because the risk of recurrence of SCAD has been retrospectively linked to three things, and that is lack of a beta blocker, presence of fibromuscular dysplasia, and untreated hypertension. So I do aggressively treat blood pressure. I do try my hardest to get them to tolerate a low dose of beta blocker, and we screen for fibromuscular dysplasia.
Oh, this is such important advice because at least as a GP, I would now know what I need to make sure the patient don't come off these drugs, just stay on it.
And I can add, David, if I could, that both SCAD and FMD are commonly associated with migraine headache. And indeed, some of the genes that we've found are linked to SCAD and fibromuscular dysplasia are also linked to migraine. For example, that PRACTA1 gene I've been talking about, that's a gene that's also associated with migraine. And probably this makes sense because migraine, as your listeners all know, is just another disease of vascular dysregulation. It's a disease of vascular tone, right? You're getting vasospasm in the brain and things causing headache. So one of the old treatments for migraine is propranolol. So propranolol is a preventive agent for migraine. So if in my SCAD patients that also get migraine, I try them on propranolol if they don't have asthma, because as the older listeners will know, propranolol can trigger asthma. But if they don't get asthma and they do get migraine, they often love propranolol, and they come into the clinic saying, yeah, that propranolol, I haven't had a migraine for the last month and it's fantastic. So they do tend to respond well to propranolol. So that's one of my little tips, if you like.
Oh, fantastic tip. What is the most important thing for medical professionals to consider when a patient is diagnosed as having had a SCAD heart attack?
Yeah, so the risk of recurrence of SCAD is debated a lot. It's probably in the order of 20 to 30%. Some series put it higher than that, some put it lower than that, but it's probably of that order. And the psychology of SCAD is very challenging. And I always go to great lengths to acknowledge to all the SCAD patients I see the psychological challenges that this brings. I mean, here you've got a woman in the prime of her life, and the last thing she expects to be doing is having a heart attack. And I think coming out of the blue in that age group, totally unexpected, is very challenging to process mentally. So I do always acknowledge that. I'm at pains to acknowledge that. We do refer sometimes there's some support groups, occasionally to psychologists, psychiatrists for support. I will occasionally I'm obviously no psychiatrist, but I'll occasionally even initiate medications like citalopram, because that can really help with the anxiety and the mental anguish around SCAD and the risk of recurrence of SCAD. So that's, I think, a really critical piece to be aware of. And I think a part of SCAD that GPs can actually really help a lot with. Because all this fancy, delicate balance of antiplatelets and what beta blocker and all of that, I mean, maybe that's better for a specialist. But I think the ongoing care is, and the mental care is so critically a part of SCAD, and helping them, because they're petrified they're going to die, and these young kids they're going to be left without a mother. So that's a really, really important thing, I think, for us all to be aware of as we manage these patients.
Oh, that is such an important point, Jason.
Yeah.
I can just imagine what they're going through, poor things.
And I do have a standard list of things I tell them, and I think it's probably interesting for the listeners to hear this. So the chiropractor's out. I just say full stop, chiropractor's done, because there are some tragic, well-reported stories of neck manipulations in these women with softer arteries causing carotid vertebral artery dissection, causing stroke and even death. So the chiropractor is out, full stop. Yoga with aggressive stretching, particularly aggressive neck stretching maneuvers, is out. Any activities where they're at risk of sudden acceleration, deceleration is out. So by that, I mean bungee jumping, parachuting, gentle roller coasters are probably okay, but crazy roller coasters not. Motocross racing, car racing, bungee jumping, all of that stuff is out. And most women just look at me like, come on, you're kidding me. But occasionally I've had women say, what, I can't race rallycross anymore? That's my life. And I say, no, you can't race rallycross, because if you get a good, acceleration, deceleration injury, that can cause whiplash and that can cause neck dissection. And I've got a couple of patients. In fact, one of them was actually recently written up in the Australian in relation to one of our stories that has had a neck dissection. And I had to stop her racing cars. So I think all of these things are important. And the final one, which is I think worth knowing, is that fluoroquinolone antibiotics, so that's ciprofloxacin, levofloxacin, they have a black box warning against them as being linked to arterial aneurysm and dissection. So I basically tell all my SCAD and FMD patients to just consider themselves, they're not technically allergic, but they're strongly contraindicated in those groups. And as you know, occasionally we do use something like ciprofloxacin or levofloxacin for UTIs and other reasons in young women. So that's a tip worth also knowing about.
Yes, now I'm beginning to understand why some patients have their rupture of the Achilles tendon there.
Right, that's another complication of the fluoroquinolones. Because again, it's a very simplistic way to generalize things, but softening of the tissues, right? Softening of the Achilles tendon, arterial dissection and rupture. You can see the common theme there.
So two other simple questions for you, because we have women who are very active. What about those who like to climb very high altitudes and those who love scuba diving? Any issues with that?
Yeah, that's a great question. There's really no data. I always encourage light to moderate aerobic activity. And I think as everybody listening knows, light to moderate aerobic activity is fantastic, not only for cardiovascular health, but for mental health, for general well-being, for stress, for anxiety, for all of those reasons. So people with SCAD and FMD should be strongly encouraged to participate in light to moderate aerobic activity. Heavy weights lifting, because severe extreme physical exertion is a risk factor for SCAD. I limit heavy weights lifting. But if they want to do weights classes, they should limit it to, around 20 pounds at 8 kilos or so. In terms of high mountain climbing, I have had people want to do that, and scuba diving. I don't think it's wise. There is no data. I've never had a SCAD happen while someone is down scuba diving, but you can imagine it's not of all the places to have a SCAD, underwater, 10 meters down or further doesn't seem like a great idea. So I tend to say, snorkeling is probably fine, but I'm not a fan of scuba diving. Going mountaineering or up high mountains, again, I'm not sure. There's also a vogue at the moment. I'm sure all your listeners know people are doing these ice baths. And is ice bathing good? Well, there's no data, but there's anecdotal stories. There have been a couple of SCADs with these extreme physiological changes, plunging into an ice bath, going to high mountains. It just doesn't seem intuitively wise. So what I tend to do for my SCAD patients is after, a couple of years out from a SCAD, they're feeling a bit more confident. They want to go traveling. They want to go hiking. I tend to tell them to, not go off grid. Going way off grid, going to the back of nowhere where there's no medical help, the Tasmanian wilderness or wherever it may be, it just doesn't seem intuitively right to me. And I think there's a lot of things that people can do where they don't have to push themselves or go to those extremes. So I tend to do that. And I think to be honest, the patients appreciate that, and they feel a bit more confident to do travel and activities, a bit closer to major places where if they happen to get in trouble, there is help close by.
Jason, this has been so fascinating, and the advice you've given us so practical and, so everyday for us. I really appreciate that. So how about some key messages to our listeners?
Yeah, so thanks, David. I think the key messages are that we all need to be aware of SCAD. It's increasingly recognized. It probably accounts for about 1 to 4% overall of acute coronary syndrome, but it is the most common cause of acute coronary syndrome and myocardial infarction in women under 50, can occur around the peripartum period. The management is slowly being worked out. We know that initially after a SCAD, we prefer a conservative management. We try to avoid stenting. We initially will often start aspirin and Plavix, but we tend to stop them much, much sooner than we would for an atherosclerotic MI, because part of the pathology of SCAD can be due to bleeding in the arterial wall. We tend to like to keep beta blockers going in these patients lifelong. That can be a challenge. But as we've said, there are some tips and tricks. I try propranolol if they're having migraines. I'll try to swap, metoprolol, bisoprolol, even carvedilol at times. And I try to find a combination that will work for them. Certain things are out: the chiropractor, extreme yoga positioning, activities of acceleration, deceleration risk like bungee jumping, motocross, car racing, they're all out. But light to moderate aerobic activity is always in for almost all our patients, and I strongly encourage them to do that. And finally, I think being aware of the psychological burden of SCAD on these predominantly young women, having an MI out of the blue in the prime of their life, it really takes a lot of support to get them strong and get them back, getting on with their lives. And fine to say that recurrence does occur in 20%, roughly 20% of women. That's an added psychological burden. But thankfully, most recurrences are less severe than the initial event and can be managed. So, and I think also SCAD is a complex disease. The knowledge is evolving fast. And I think, specialist cardiology referral is the way to go, and making sure they're connected into all the necessary services, whether it may be, mental support services, physiotherapy, cardiac rehab if they've had a SCAD event. All of those things I think are really key to give these patients the support they need to move forward after their SCAD.
Jason, that is fabulous messaging. I just add that there is this association with fibromuscular dysplasia. And so for all the listeners, please tune into this next episode with Professor Jason Kovacic, where he will be speaking on FMD. Thank you so much for your time and teaching, Jason.
David, it's an absolute pleasure. Thank you.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.